Hello, good morning, good evening, everybody. So awesome that you guys can join us tonight, this morning, wherever you are in the world. We have broken a internet record. I think we have 1,600 people registered for this webinar. So if you are here in the Zoom room, congratulations, you've got a seat because not everybody's going to get a seat, unfortunately, because we are oversubscribed to this. So awesome to see you all in here. As normal, please let us know in the chat where you're dialing in from. It's always great to see familiar faces in here. Some people I know personally, some people I know through webinars. So Dr. Brooks and I are here today. Dr. Brooks is here to talk to you all about eye emergencies. So we might start and say, welcome, Dr. Brooks. It's so pleased to have you here today. Okay, what have we got? Montana, North Carolina, Australia, Iowa,
Austria,
New Mexico, Virginia. Oh, this is going really fast.
Texas.
Let me see if I can. Oh, goodness. Kentucky, Arizona, UK, Iowa. That is going so fast, I'm having trouble keeping up with it. Good.
Egypt.
India. Wow, that is so cool. So I think we've actually also broken a webinar record with the number of countries people are joining from today. So very cool. Thrilled to have you
Quebec,
all in today. South
Sweden,
Africa, Canada, Sydney.
Lithuania,
Yeah, New
New
Zealand. Hello,
Zealand.
Patrick. That is very cool, isn't it? Okay, wonderful. So we are going to be talking to you, Dr. Brooks, Professor
Hurrah.
Brooks, actually. So we shall we mention that? Professor Dennis Brooks,
That's
who,
correct.
by the way, is the only veterinary recipient of the AAEP Milne Award and the recipient of the Beaver Smith Memorial Medal, which is a great honor. Congratulations. I hope you are very proud of that one.
I am. Yeah,
Good.
excellent.
Yeah,
Yeah,
wonderful.
unique.
It is very unique, yes. And something that I can tell all the attendees here, and something I shared with Dennis yesterday, is all the lovely messages that everybody has been writing on many of the social media ads and replies to the emails that we have sent to you saying how wonderful you are and how much they have learnt from you over your teaching career, and even some from horse owners saying, Dr. Brooks saved my horse, which is just, it's really lovely. Nice to get reminders of those. Oh, here we go. Emily, hi from Tampa. Love to Dr. Brooks. He is a wonderful resource for eye cases here in Florida and around the world. That's the
Yeah.
that's the purpose. Yeah, wonderful. Okay, we are going to be talking. Dr. Brooks is going to be talking about eye emergencies in horses today. We are going to. He's going to be sharing a screen shortly to give you guys all some education. We will be touching on collagen cross-linking because everybody's going crazy for that right now, but just to let you know, there's some more training on that coming up a little bit later on. Just a little bit of housekeeping for the questions. We would love to take your questions here. Please put them in the Q&A because the chat gets so busy, we will miss them. So put your questions in the Q&A just as you go along, and Dr. Brooks will answer those at the end. And to save duplicates of questions, Dennis, I think we're ready to start. What do you think?
Share.
Yep, we can get going. Share your screen.
Yeah,
It's
let's
just
get
you and
here.
me and a couple of thousand of our closest friends.
Here we go. Hi, everybody. This is Dennis Brooks in Florida. I'm going to go through a variety of cases, and I thought that I would talk about emergency eye diseases. And let's define an emergency as the first time you've seen it, because there can be acute situations and chronic situations, and there's a variety of things to discuss. This is a very exciting time in horse ophthalmology internationally. We have new eye diseases in the horse eye. We have new therapies for some of the older diseases. We are understanding how the horse deals with injuries and illness, and I'll talk about that individually and specifically. It's an amazing time here. And so today, let's just go along and we'll see if we can get started. There we go. Here's a horse that's squinting. I'm going to talk about some individual cases and try to get you interested, and then we'll break this down into some specific techniques and so forth. The squinting horse. Squinting and tearing, right? Or got some sort of a purulent disease here or purulent eye disease. Are you ready? Somebody did a nerve block on this horse already. And we'll talk about that too. A clinician has examined this eye and sent that previous picture to me and sent the next picture you're going to see. And then that person called me. Are you ready? Okay, here we go. This is a little video. Now you watch this. Watch. It's short. They're going to watch the video. Ah! You want to see it again? Ugh, oh my God. there's a big hole in this horse's cornea. And so the whole idea in the course is how are we going to fix that? And I'll speak about this specifically in 15 minutes or so. This was H.C. Pignon, who's one of the speakers in this course that we're proposing to do. And H.C. saw this in Mexico City. And so I'd never seen anything like that, but we'll come back to that. Welcome to my world. Did you feel the panic in that last picture? I've seen it, I don't know, 10 or 15 times. I get stunned by it. Panic is an interesting feeling. And I feel it every time I go to work. I feel it. What am I going to do now? And it's not necessarily negative. It's energy. It's creative energy. And when I'm panicked, I shut my mouth. The owner's standing there, the horse is here, everybody's watching, and I feel this negative energy, but it's not really negative. It's useful. It makes me creative. And I'm trying to go through that, why it does that, and help you deal with that feeling as well. Remember, most of the time, the horses that you and I both look at, they're going to get better. Maybe not the last one, and the injured horse eye needs our help. And I'm going to show you some examples, though, of horses who got no therapy at all from us and healed themselves. And that's an important thing for you to realize. The horse eye knows how to heal. What we need to learn is how to help it and not get in the way. Okay? There's always a sense of urgency about looking at horses with eye problems. And I'll explain that too. The horse eye can change dramatically very quickly. If you're called in or somebody notifies you about a horse with an eye problem, go see it as soon as you can. A week later is probably too long. 2 days may be too long. I know you're all busy and you have busy schedules, but depending on what the eye problem is, a few hours can make a difference in your ability to get them to heal. An eye exam while you're feeling panicked. I thought about today showing a picture of me working, and then I thought, no, nobody'd care about that. And what I do when I see a horse. And very quickly, I walk in the room, I see the horse, it's standing there, the owner's there. Within 15 or 20 seconds, I evaluated the comfort of the horse. I figured out whether this is a vision problem in the eye that's affected. It's called evaluating the dazzle reflex. Most people that are watching me never see me do it. I just learned how to do this, and this is what I'm going to teach you. You need a bright exam light. It doesn't have to be an expensive light, but it has to be bright. I'm using that bright light to look at the cornea. It should be shiny really quickly. Now, if the horse is squinting, I'm going to have to do a nerve block, aren't I? But seeing the horse that's squinting, noting that the horse is squinting, is an important finding. Early on, I look at the pupil size and whether the pupil's responding to light, and most veterinarians don't look at the pupil, and the pupil is providing us information. Make sure you look at it. Now, if the cornea is really cloudy or there's hyphema or something, it's hard to see the pupil, but that's an important finding. Look for aqueous flare if you can. Look for hyphema, which is blood in the anterior chamber. Then at some point early, sedate them. Don't think that I can't do a good eye exam if the horse is panicked. Anyway, I'm panicked. Unfortunately, the horses feel my panic, I think, sometimes. Do nerve blocks. I'll show you where I do it here shortly. And every horse that I examine, everyone gets photographed and I fluorescein stain them. Everyone. I see people trying to do eye exams without doing some of these things. And I go, I can't do it. How can they? Photograph the eye of every horse patient and then look at the image right then. You'll see things in that photograph that you didn't see when you just looked at the eye. It's important. I do this in every case I look at. Not 50%, not once in a while, all the time. And try to do this before you stain the cornea with fluorescein, okay? Because it'd be nice to have a pre-fluorescein stain and a post-fluorescein stain. And we'll talk about that. Everybody's carrying a camera. They call them phones, right? Take pictures. If you're not sure how to do it, the joke is, if you can't do it yourself, find a 10-year-old kid to do it for you because they're not afraid to just take pictures. The pictures I'm showing you tonight or this morning are ones I took. And I photograph everything. It's imperative. Now, I just want to throw in some ideas here before we get to more cases. I call it the mantra. Things that I have found to be truthful. And these are some things that I was taught were the opposite. I was taught the horse eye heals very poorly. No, the horse eye has very powerful healing capability, especially the cornea. But it doesn't control the healing processes very well. And I'll show you that too. But the healing is there. It's just we have to help it heal. We have to help the horse eye control what is happening and not make it worse. Therefore, because horses don't control the healing process very well, the healing mechanisms, healing of a horse with an eye problem can be rather slow. Things to think about. If I look at a horse's eye and I think it's comfortable, I look, it's got its eye open, and the owner tells me it's had an eye disease for a while, and I think it's okay, it's not. The horse is real good at hiding how it feels. Real good. Now, when you sedate it, you may get a true feeling that's when the horse will droop its eyelid. That's when the horse will show you it's uncomfortable. If you think there's no uveitis in the horse's eye, you're probably wrong. It's there. If you think there's aqueous flare, which we'll define later, if you think there's aqueous flare in a cornea that's edematous, you can't see it, but you can see its pupil. So look at the pupil instead. And this is a big one for me. This slide is something that I realized over time. If the horse has damage to its cornea, the horse responds to that by getting rid of those damaged cells, getting rid of that damaged collagen, getting rid of the damaged tissue. So that's what it does. And if so our job is to help the horse minimize the damage, because it's going to get rid of the bad tissue. This is why a superficial ulcer gets deeper fast. Hey, guess what? It does that whether it's infected or not. And this is a big thing. I see veterinarians dealing with horses with corneal ulcers, and things aren't going well. So they switch antibiotics or switch antifungals. That maybe sometimes that's indicated, but more often than not, it's not an infectious problem. The sloughing, this altering of the corneal cells is mediated by enzymes that are in the tear film and they're mediated by neutrophils. The bacteria and fungi really don't make things worse. They just start the disease. Ulcers get deeper due to excessive enzyme activity in the tear film and the tissue. Sterilizing an ulcer doesn't guarantee it's going to heal. It doesn't guarantee it's going to heal. You got to change it. It took me a long time to change this mindset, but I still feel it. Things aren't going well. I want to change drugs. Even though in my heart and my brain, I know that's not the answer. And we're going to provide those answers to you. The top thing you can read at the top sentence: in horses with eye problems, when you think things are better, when I think things are better, they're usually not as good as I think they are. Because what happens is when I think that way, when you think that way, when the owner thinks that things are better, they want to stop the medication. And it may be too early. I would prefer to wean the horses off the medicines, to slowly take them off. And I usually stop the antimicrobials first. Horses with serious eye problems, they need a lot of your attention. And you're all busy. I know this. But you need to go back. Seeing them next week may not be appropriate. Seeing them 2 days may be the best you can do, but even that may not be the best thing we can do. Equipment. What do you see in this picture? You don't see much. You don't see much. You need a light. You got a light. Then you can see, this is one thing. This is why I want you taking pictures of these horses during the exam. And look at the picture then. I want you to look at the reflection of the flash in your camera, the reflection from the tear film. This is incredibly important. It should be a circle of light. It should be shiny. The tear film covers the cornea. It should be shiny. Horses get dry eye very commonly. I was taught they didn't get it, or it's very rare. No, it's extremely common. And how do you evaluate it? By looking at this flash. the reflection of the flash from the camera in the tear film. In this picture, blue, which is edema, you see some red, some blood vessels. The pupil doesn't look too abnormal, depending on what the eye problem is. You can see the drainage angle over here. It's a little bit dark. I'd probably reshoot the picture again. But this is how you need a light. It doesn't have to be an expensive light, but it has to be bright. This is the light I use. People say, what do you use? I use a Pelican light. It's a 1910 light. It's powered by one AAA battery. If you get a flashlight that has 3 batteries in it, it'll be too bright. There's a happy medium. But this is what I can do 90% of my ophthalmology to the horse with this light. It's a little pen light. I lose these things all the time. But I buy another one. Left them all over the world, I think. How do you tell if a horse is comfortable or not comfortable? You watch the position of the eyelashes on the upper lid. Horses are real good at hiding their discomfort, though. They're real good at it. And so sometimes you won't see the droopiness until they're sedated. The picture on the right shows the normal eyelash position. It's almost on the upper lid. It's perpendicular to the cornea. And then it starts, when the horses feel bad, they pull their eye backwards and eyelashes droop. When they feel better, eyelashes come back up. There's a few horses go through life and this is normal for them, but that's pretty unusual. Always check both eyes. How do you evaluate vision? The dazzle reflex. I see people waving their hands in front of horses. Yeah, okay, fine, but that's not very good. It's better to do this kind of thing. He blinks. It's called a dazzle. Now they blink in both eyes. This video doesn't show that. If you shine a light in the bad eye, the good eye is going to blink too. Here's a dazzle reflex. It's much more sensitive than the menace or hand motion if the cornea is cloudy, for sure. And I do this all the time. I don't do menace reflex anymore. It's just a waste of time. But I do this. I get the pen light in my hand. I walk up and I check the eye's comfort, the eyelash position on the upper lid. And I shine a light at them. Most of the time, the owners don't even see me do it. You need to know whether the retina is working in these cases, right? The dazzle reflex, if it's positive, and I'm going to show you an abnormal one here in a minute. You need that information. Many times you are too, working on a horse with a really sick cornea or maybe uveitis, and we can't see the back half of the eye. We can't see the retina, even if we have an ophthalmoscope that'll let us do it. We can't see it, but we need to know. The owner needs to know. The owner needs to know whether we're going to have a visual eye, depending on what we're treating. If the cornea is sick, I was taught if the cornea is sick, that the retina is sick too. That's wrong. The horse is real good at compartmentalizing inflammation. The inflammation's in the cornea. That does not mean that it's in the retina. But you got to show that to yourself. You got to test that for you. It's real easy to do. Hand motion's too much variation. Here, let's look at this horse. Blue eyes, edema, look, nothing. But I'm not sure, so I go to test the good eye. Boom. That's what it should look like. So test both eyes. Let's do it again, just for fun. This eye has glaucoma. That's why pressure inside the eye is too high, and he's blind. So that influences what options I'm going to offer the owner. The left eye is fine, thank God. But somebody asked me, what if the horse is already squinting? What a great question. I was so stupid, I didn't think about it. If the horse is squinting like this guy is, how do I check the dazzle reflex? How do I check it? Don't block them, right? You're going to see me. I'm going to gently lift the upper eyelid up, and then I'm going to shine the light. And you can't hold the eyelid open. If the horse wants to squint, that muscle is powerful. So just watch this. Let me see if I can get. Here we go.
Are we ready? Good.
See, the cornea is really sick. See, it's yellow. Boom, he's shut. See, I don't have a lot of force here. Let me show you one more time. If they're squinting, this is what I do. And I recommend that you do the same. But see, this cornea is really sick. The owner needs to know, you need to know what, in order to advise proper therapy to refer it or not refer it, whatever, it's what's the chance this eye's going to see? Everything depends on that. We have to evaluate the visual capability in every eye exam. And this is how I do it. And I'm really pleased with the results. Here's another squinty eye. Horse is painful. You just never know what you're going to see. And there, oh, God bless, right? What's this? This is a lens. This horse is a ruptured cornea. There's the lens. This eye's not going to get better. Then I pull the lens out of the way, and here's the iris. So this is a ruptured eye. Does not have a dazzle. Okay. So, I've had people want me to repair these corneas but enucleation is the most humane thing. But we'll discuss that in the course. Now, I just saw this case. I should leave the audio on of this. This horse has a dazzle. Okay, but he's got a nerve block now. So just watch the video. Oh, what's that? What's that? Watch it again. Now, here. What color is this horse's pupil? What color is it supposed to be? It's supposed to be black. So, something floated by. Something's hitting the back of the iris. And this horse has a lens luxation and due to uveitis. But he has a dazzle. The horse is visual. I can't believe it. You just never know what you're going to see. Iridonesis means the iris moves because of contact with the lens. Okay, now this picture really changed my professional life. So look at the things we see. You got question marks up here. Now, the picture's not good, but the corpora nigra here are going up to the back of the cornea right up in here. That was the best picture I could get of it. But look at these things. Do you know what these are? These are called retrocorneal, behind the cornea. These are in the anterior chamber. Retrocorneal fibrotic membranes, RCFMs. Retrocorneal fibrotic membranes. These only show up after a cornea is ruptured and healed. It's collagen. This horse is a thoroughbred mare, and it had been out. It had two normal eyes. It got put out to pasture, and several months later, as happened in some of these thoroughbred farms, and it came back. They went out to get it, and it looked like this. It was normal. Went out to pasture, and came back like it got no therapy at all. This horse had ruptured its eye. It had an iris prolapse. Look, here's the pupil. This horse can see. This horse got no medicine, no therapy at all. This horse changed my career. It showed me that the horse has tremendous healing properties. How do I help it heal and not get in the way? And I've seen this several times. I've been doing this a long time, so I've been lucky enough to see a whole lot of different kinds of cases. Not everything by any means. Like I showed you the picture at the beginning of the horse with the hole in his cornea, it's leaking. It's shooting aqueous humor out. That's the first time I've ever seen that. But it's like the horse has the ability to heal. How do we help it heal? I was taught the horse eye heals poorly. That's not true. It heals tremendously well. We just need to learn how to help it heal. This is pointing out the fibrotic membrane. This is an end result of an iris prolapse that got no therapy. This pigment here is superficial. It's not the iris pigment, but it's just there. Take pictures of the eye and then examine them. Now, there's one of the lectures in this course is a guy named Tim Knott. Great guy. He's got a website called theiphone.com or www.theiphone.com. And please go, if you're interested in this, take a screenshot right now, get this here, get this down for you, and write Tim. Tim's one of the best veterinarians, veterinary ophthalmologists, best people I know. He's a great guy. He'll answer you. You got questions. And he's got lists of cameras. Whatever camera you've got, he's got lists of cameras telling you how to use it. Because all the cameras are a little different. Contact him. Okay, are you sure we're going to look at a couple cases. This is the first case. Are you sure you want to see it? Look at this is a piece of wood. It's, I don't know, 8 or 10 inches long. Poor horse. It went into the orbit. It blinded the horse. I can't stand to watch that. We're gonna horses to find way. Here's another horse. It's squinting. He's squinting, and the eyelids are swollen. Now you can just have blepharodema. A horse can hit its eye, and the whole eyelids are swell, but the rest of the eye is normal. But look what else happened. He's got a big corneal ulcer. It's a laceration. And then eventually we found out here's a CT and he had a fractured skull. I think maybe I've got an arrow pointed at the fracture, and like the sinus is filled with fluid and it's okay on the good side, and the other side's this guy's got some serious head trauma. But I got called in to look at this. He's got a big ulcer. Is this a superficial laceration or a deep laceration? We're going to look at another one of these later in detail, I promise, today, right now, shortly. But look at laceration. It's deep, dark is deep. Do we suture it or leave it alone? That's the dilemma. It's a laceration, but it's not full thickness. But it's deep. We'll go back to that. Another pain. This is a painful horse, right? What are you going to do? Sedate him, block him, check a dazzle, and then hold your breath. See what I saw this. It's brown. Cornea is cloudy. He doesn't react. He just doesn't have a dazzle. And there's enough cloud. I can't even see his pupil. So what's an option then? How do you look inside? Most all horse vets are carrying ultrasound machines. Ultrasound him. And then I got the answer. Here's what we got. Here's the ultrasound. Here's the corneas at the top. I just touched the lids. I didn't touch his cornea. I just got the probe on. It's a 10 megahertz probe. I just got it on his cornea. And so the cornea is up. Here's the back of his eye. But then this is behind his eye, and the orbit it's called a reflection artifact. There's something metallic in his eye. And we enucleated it because it was a blind eye, and he's got a BB or a shot in his eye. Accidentally shot on purpose. I don't know if the accident's there. And so we determined this by his clinical appearance, but also the ultrasound. We have a lot of stuff about ultrasound in the courses. Let me start this again. Nerve block. People do it various places. Let me stop it. So I do it at the highest point of the zygomatic arch. The closer to the ear you get to block the motor innervation to the eye, the closer to the ear, the better block you get. Here's the base of the ear right here. Here's the ear up here. The pin is up here. So let me start again. Come on. There we go. I'm palpating it. The nerve runs this direction from the base of the ear, runs this way. You can palpate it. You can also palpate it down here. But the closer to the ear, the better block I get for motor innervation let's keep the eyelids from interfering with our examination, or to relieve the spasm so that we can get a look at the cornea. Got to do a nerve block for most of the time. Colors. This is one of my favorite slides. Colors. Colors in the cornea. Whitish yellow is neutrophils. I wish it was macrophages. It just won't be. Neutrophils. There's some corneal injury here. Neutrophils got attracted. They can get there very fast. The average horizontal diameter, limbus to limbus of the horse eye is 28 millimeters, and neutrophils can move up to 40 millimeters a day in the cornea. They get there real fast. But think of this for a second. So the neutrophils come from the blood. But there's some blood vessels here. We'll get to them in a minute. But this is a distance. But if they're squinting, the conjunctiva has blood vessels in it, and the conjunctiva is on the inside of the lid, and the conjunctiva is going to be, because they're squinting, is right up against here. There's no distance to migrate. They're there. So if they got a corneal injury and they're painful, and the cornea is one of the most sensitive tissues in the body, they're going to be squinting. And we need to relieve that pain as best we can medically, because if we let the migration of neutrophils continue, we're liable to get a really deep ulcer or a corneal ulcer that it doesn't respond to our therapy. Up to 40. The classic example of this is one of my practitioners here locally in Florida. She weaned her own horse. She weaned the baby, weaned at noon on a Saturday. The baby got upset being separated from its mare, and so it ran around a little bit and accidentally bumped its eye. She saw it at noon, 12. 5 hours later, she went to look at the baby, and she had a horrible melting ulcer in 5 hours, meaning the corneal ulcer was really deep. The eye was about to rupture. She said she wouldn't have believed that it could happen that fast if it had not happened on her own property. Blue is edema. It's just water. But the horse cornea can accumulate water superficially or deep in the cornea. How do you tell superficial from deep? Now look at the reflection from the camera, the photograph. Look at the reflection in the tear film. It's not just one circle, it's a whole bunch of little ones, because there's lots of superficial bubbles here. If you see this kind of thing and use a hyperosmotic, it's more likely to respond than if you just see a circle. If the edema is really deep, hyperosmotics don't work. You can still use them anyway, but the chances of having a dramatic change are not very good if the edema is deep. If the edema is superficial, hyperosmotics like 5% sodium chloride work better. Blood vessels, somebody said one time that corneal blood vessels are smarter than we are. Watch them. They're giving you information. They're giving me information. They're oftentimes pointing directly at the lesion. I mean, look up here. Here's the limbus up here. There's no blood vessels at all. They're all down here. It's obvious on this one. Sometimes it's not so obvious. Note the intensity of the red. These are flaming red. These are really, I say they're real interested. If they're pale, it's like they're there, but they really don't care. Blood vessels move in the horse cornea about 1 millimeter a day. It takes 2 or 3 days to start, and then the vessels move. Too much flunixin systemically will slow this down. Bute, not as much, Equiox, not as much, but I use lots of flunixin as a systemic nonsteroidal, and I have to watch the dose. If you give them too much, maybe a full dose, I try to give them a half dose. Fluorescein, every eye gets stained. Not 50%, stain them all. I do. I've done it for 45 years. I usually just wet the strip with some saline or something, and I touch it to the limbus or touch it away from the corneal surface. But some people like to tear this off and put it in a syringe and gently spray it up on the cornea. I get that, but you're diluting the fluorescein doing this. You'll miss things. I use it full strength. I just wet this and get full strength. It's up to you. You can see a corneal ulcer without fluorescein sometimes, but it's just better with. See, and then when you stain it, a corneal ulcer, when it heals, will become a circle. This is not a circle. This is actually, see the projection? This is called a tongue. I don't care if you remember that, it doesn't matter. But this, as it heals, it will become a circle with smooth edges. Did you hear me? Because people sometimes, if the edges are rough, we need to debride them. I'm not going to talk about that today. But if the edges are smooth, you don't have to debride them. But if they're rough, the cells are dysplastic and they need to be debrided. Horse ulcer heals about 1 millimeter a day. 5 millimeter diameter ulcers take 5 days to heal. You with me? 5 millimeter diameter ulcers should take about 5 days to heal. If it's longer than that, something's wrong. If you or I put medicine on the horse's cornea, that medicine is there 7 minutes. It's not there very long. And so these are important numbers. how fast a corneal ulcer heals, how long medications stay there, how fast the cornea is vascularized. These are important numbers. They help you figure out what's going to happen next. You institute therapy, and then what are you going to do next if the therapy doesn't work? I'm going to stop this a second. Look at here. Blood vessels are here. This has been going on a few days, hasn't it? This area yellow, this is not fluorescein. This is the cornea. This is yellow abscess. But look, dark is thin. Dark is thin. But the eye doesn't look bad. It's not collapsed. So it's got a thin area. But how do you tell if an ulcer is really deep? Meaning, is it ruptured? You do what's called Seidel's test. Seidel was a person, so it's apostrophe S. Seidel's test. So I got this horse, the nerve block. I don't want him blinking. I've numbed his cornea because I want to touch it. I want to paint the fluorescein on, and I don't want him to blink. Seidel's test. And just watch. Oh, the color is changing because there's aqueous. See, dark is thin. See the dark area, but it's actually a hole. Wouldn't you think that a horse that had a small hole in his cornea would be painful, would have low intraocular pressure, would have the pupil small? Wouldn't you think all these? Yes, but that's not what they do early. If it's a big leak, it's called a micro leak. This is significant. If this is leaking, you need to be ready for it. And I'm going to prepare you for that here shortly, okay? Because this is important. It's one of the reasons we're having this seminar today. Closed lids, when the eyelids are closed, bad things are happening to the environment of the cornea and tear film. Just remember that, okay? We don't have time to talk about it. You look at this eye. Blue is edema. There's a few vessels here. Real thin area, huh? So these are white neutrophils in the cornea. This is hypopyon. This eye's in trouble. I didn't get this eye better. I didn't get this eye better. Treatment was antibiotics, antiproteases, treat through uveitis. Now, I'll show you a list in a minute. I didn't get this eye better. I'm still angry about it. I wasn't good enough. I'm still mad about it. I wish I'd have had this. This is something called collagen cross-linking, and it's something that's very useful for practitioners and specialists. This is riboflavin, vitamin B2. We're spraying it on the cornea. Going to let it sit there about 20 minutes, keep spraying it. I need 1 cc of riboflavin. And then we're going to stimulate it. Now, I've calculated out from how much light, UV light it provides, how far away I have to be from the cornea to get a specific amount of light energy. And so I know where to be. This is not just haphazard. And then I'm going to do this for 6 minutes. I do it sometimes weekly. Sometimes I do it daily. This helps the cornea heal better. Helps it heal better without a scar. And it's not you can buy a $2,000 laser if you want to, or you can get a $45 light. But it's very useful, and you're going to hear more about this. Okay. This is an eye. Blue is edema, red is blood vessels, yellow, white is neutrophils, dark is thin. Now, but what do you see here? I took a picture of this, and you see this little white dot in the center of this dark area? I didn't see this with the light. I saw it in the picture. You know what this is? This is a leak. This is leaking aqueous. There's a hole here. And this is a nice horse. These are nice people. They don't have many money to go to surgery, but they care about this animal. That's why they come to see me. And I took an oath to help animals and help people that owned them. We all did. Not everybody's got a lot of money, but that doesn't mean that I can't try to help them. And so here, I'm going to show you what I did, and it worked. And I was ready to help. So what I did was, and I'm going to show you the pictures. What I did was with cotton swabs, I dried the horse is sedated. He's standing up. I dried this area up, and I had a patch. See, the ulcer's deep because there's tissue missing. There's tissue missing. And what I found out was replacing the collagen, replacing the missing tissue, increased my success rate. So I'm going to use glue. Various kinds of glue. This is the one I used. It may not be available in Australia or anywhere else, but there's options there. That's not critical. Now look though, don't glue a descemetoceles. I'll remind you this in a minute. I'll explain why. But a small little ulcer that's already leaking, perfect. I'd love to suture it. I've used another glue called Gluture. This is a veterinary product. There's various veterinary glues. So I got a patch. This is actually small intestinal submucosa from a pig. You can buy these little discs or make them yourself, whatever. But I'm taking the glue, and look, I'm pointing up. I'm pointing up. If you point down, the glue is going to run out. I've glued my hand to the eye. I've glued gloves to the eye. I've glued instruments to the eye. It came undone, but I don't like that imprecision. So I'm putting the glue around the edges. I've dried the cornea. In the meantime, somebody's drying the cornea, drying up the tears. Now, the glue doesn't set till you touch it to the tissue. You can put the glue up here. It's still sticky. And I glued it. I stopped the leak. This is 2 weeks later. Most of it's fallen off. There's still a little bit of it's not leaking anymore. And 3 weeks later, I'm all done. Yeah, I got a scar. I'd love to see this horse now. This was a number of years ago, but I bet the scar went away. But I saved the eye, though. And I saved the eye. And I helped these people. There's another squinty-eyed horse, and here's a descemetoceles when I looked. You don't glue one of these. The glue will rupture it. Because when the glue hardens, it sets off heat, and it'll pop this. If it's already ruptured, glue it. If you understand? There are limitations to all these things. You learn the indications and contraindications. Another painful-eyed horse. Let's look at him. Let's look at him. Sorry. He's unhappy. I got a subpalpebral lavage, and I'm already treating him. Interpret this for me. He's going to slow down here in a second. Blood vessels are there, right? There's the yellowish white abscess area. We get a better look, sorry. There, he's a little calmer now. A little more sedated. I can't see his pupil. Can any of you? But this is what he looks like. Well, I've been working on him, but if I seen that initially, I would have got a little panicked. Corneal ulcer management, we're going to sterilize it just a little briefly. Sterilize the ulcer surface, antibiotics, antifungals, maybe if you live in an area that has fun. You got to reduce the enzyme activity. How do you do that? Reduce the corneal edema. Treat the uveitis. Do anything we can to reduce the potential scarring. And if there's tissue missing, this is a huge thing. Nobody taught me to, if there's tissue, the horse cornea is 1.5 millimeters thick. 1.5. And here's another one. Look at the cornea, it's so soft, it's running over the face. So we're going to cut this off. We'll teach you how to do that in the course. Look, this whole cornea is melting. Look at all the options to reduce enzyme activity. We can use serum to reduce enzyme activity. If you use serum, you replace it every 8 days. Where do I get the serum? Red top tubes. Let it clot, take the serum off, put it in another tube or another bottle in a syringe, let the owner spray it up on the eye. Use serum as often as you can. It's only going to be there 7 minutes. EDTA, you got purple top tubes, fill it halfway with sterile water. It's a perfect concentration. Halfway with sterile water. I use a lot of EDTA. Now, serum and EDTA don't mix. You don't, if you want to use serum, use it by itself. If you want to use EDTA, use it by itself. Don't take the EDTA that's in blood, prevent the blood from clotting. That doesn't work. Combinations. Sometimes I got horses on 3 or 4 anti-proteases. Still can't slow it down. Here's EDTA. Fill it halfway with sterile water, and that's a perfect concentration. Take it out of the tube, put it in a syringe, let them spray it up on the cornea. If you're going to use EDTA, though, it doesn't mix with other stuff. Use it by itself. Plasma versus serum, friendly debate. Plasma and serum both have anti-protease effects. Serum is best for melting ulcers because it has platelet-derived growth factors to stimulate healing. Plasma, the platelets are intact, but plasma has fibronectin in it. And fibronectin helps ulcer healing. Anyway, if horses are on serum or plasma, replace them every week. Prevent the chance of contamination. Another squinting horse. It's got hyphema, which means he's got uveitis. Red blood cells by itself are not a bad thing. They go away. They go out the drainage. But look, some of this is suspended up here. And there's fibrin in here too. Sometimes you get hyphema with fibrin. Sometimes you get hyphema with fibrin. Sometimes you get hyphema by itself. Okay. Fibrin's bad because it's sticky. If it sticks to the cornea, it'll cause permanent corneal edema. If it sticks to the lens, it'll cause a cataract. There are times when, and as far as uveitis and hyphema, you treat with systemic nonsteroidals, maybe antibiotics, atropine topically, topical corticosteroids, dexamethasone is what I use the most. Hydrocortisone doesn't work. It's too weak in this situation. Or you can use tissue plasminogen activator, and we'll talk about that in the course as well. It used to be cost prohibitive. Nobody could afford it. But now, at least in the States, and I don't know about the rest of the world, but you may be easier to get it than not. But now a veterinarian in the States can buy an individual dose, which is 1/10 of a cc. You inject it into the anterior chamber. It doesn't work topically. You have to inject it in the anterior chamber. This is scary stuff, but very feasible. Very feasible. And it looks like this. I still got some scarring here, but the fibrin's gone. This is the same eye. This is like 15 minutes after I gave the TPA. I just want you to be aware of this. Most of you already are. This is something that many of you may run into a situation where you need to get rid of the fibrin. If you get eyelid lacerations, where's the first suture go? The first suture lines up the lid margin. You got to take this and suture it up here and line up the lid margin. 2-layer closure. Put in a deep suture and do the skin. You guys handle this stuff. I don't see this stuff very often. You don't need me for this, but line up the lid margin first. Line up the lid margin first. Foreign bodies, they look like this. They look so simple. They scare me. They scare me big time because I can't tell if it's superficial, and this one was. So we just flicked it off with a metallic blade or something, just flipped it off. There's a little ulcer there, but look at this other one. This is a slit lamp. Here's the foreign body. Look, it's going all the way through the cornea. It doesn't look like much, but if I pull this out, it's going to leak. Then I'd have to glue it, wouldn't I? See it? Full thickness. This is when slit lamps are useful. Horses, I still to this day don't understand this horse. This horse was a baby, a young foal, and it had glaucoma in both eyes, and it had corneal edema, and the owner was convinced the horse could see, and I was pretty sure it was blind, but I learned real early, don't argue with people. If the owners think they can see, that's great. If I know they can see and the owners think they're blind, then that's a problem, I guess, a little bit. But edema, again, there's another painful eye. Look at that. This was an acute injury. This just happened. And the owner of this horse is a human ophthalmologist. So this happened way up in the northern United States. So I get this panicky phone call saying the horse has got a laceration. It doesn't go full thickness. This is like a deep ulcer, but it's a laceration. The horse is running through the trees, and look, this is right where the upper eyelid and the lower eyelid meet. So this went right between the margins of the lids and slashed the cornea. Question for you, suture this or treat it like an ulcer? What would you do? That was why they called me. Suture it or just treat it like so we elect the owner's an ophthalmologist, so even he didn't want, so we treated it like an ulcer. Now watch what happens. Watch what happens. So right now, it's not very wide. It's really clinician's choice what you want to do. But look, 3 days later, it's spread apart because the tissue contracts. But look, the fluorescein, the cells are growing down the side, so it's healing. But look how wide it got. And then this 3 months, it's been healed a long time. But look there's 3 flashes from the camera because this side, it's like this. So the top superficial, then this is deep, and then this is like the top one. So like this healed, but it's a scar, but it's a victory. Couple other things then we're done, but here, just traumatic edema. How do you know if it's going to get better or not? Other than trying, the owner wants to know. Edema, probably treat with uveitis, but I'd also give 5% sodium chloride topically, even though it's not likely. Look, it's one circle and a few little ones, it indicates it's bumpy. It might work, but it doesn't because I ultrasounded it. Here, the cornea is up here. And because the owner wanted to know. And here's Descemet's membrane, it's down here. So it should be up here. This is where it's not going to get better. We'll talk about this in the course several times. What's wrong with this eye? This is a painful eye. I could use this eye, I could use this picture as a picture of a normal eye. This horse is really painful. And we can't get the pupil to dilate. Won't dilate. Horse got dazzle, seems fine. Look, here's the fluorescein, no ulcer, no abrasion. I learned something on this one. There's a little bit of flare, but maybe aqueous flare, but maybe not. But I thought I couldn't get the pupil to dilate. Intraocular pressure was okay. Intraocular pressure, if it was low, then it would have inflammation of the ciliary body. This is a horse that has, if I can get the thing, has iritis. Pupil won't dilate. It has anterior uveitis, which, anyway. Last thing here. And when I first met Olivia, I really wanted to talk about this because I hate this. And I've seen about 3 or 4 cases in my 45-year career. The horse gets hit in the head and goes suddenly blind. The optic nerve is stretched because the blow to the head causes the optic nerve, the eyes to move forward, and it stretches the optic nerve, and you get hemorrhage in the brain. That's like hemorrhagic stroke in people. Hemorrhagic stroke is what killed my mother. I'm very sensitive to it. It killed both of her parents, my maternal grandparents. I'm probably at risk of this. So I watch my blood pressure very good. It's good, don't worry. But this is a disease that interests me. And this disease is in Australia now. There's a drug being used in humans, a veterinary drug. So why can't we use it in horses? And it helps people with hemorrhagic stroke, and they're testing it in Australia now. This is what one of these horses looked like.
There's a heckle of you. See it be?
I'm just walking around. I'm following this horse around the corral. He's blind. He fell over. They saw him fall down. His optic nerves look fine because that's not where the damage is. The damage is in his brain. The drug is called Desferal. It's made by Novartis. We can talk about this some other time. I've run out of time here, but I just wanted to mention this because I've seen several of these cases. If you ever see one of these, I want to know about it. You'll have my email address. I want to know. I want to help you with this if I can. What happens is they get the blood, the hemp hemoglobin that's in red cells, when it gets leaked, it's toxic. The iron in hemoglobin is toxic to the brain. That's why people with hemorrhagic stroke either die or they're severely debilitated. You can have a small stroke just from ischemia, but most people recover from that. But this is a dose that was used in foals that got blood transfusions and got too much blood. And it works. And in animal models of stroke, other than it prevents all neurologic signs. It's an iron chelator. It chelates the iron in hemoglobin. If you ever see, I want to know this. If you ever, Bob, you got my email. If you lose it, Olivia will have it. Anyway.
I am on the edge of my seat, as I'm sure everybody is in the audience. Dennis, that was amazing. And it is actually a shame that we have to stop you talking because I could sit here for hours and listen to you, as I'm sure so many of you.
Well, but everybody knows you, Olivia.
Incredible, incredible. Dennis and I have been working on this incredible new program. So we're absolutely thrilled that we can announce the official opening of the Equine Ophthalmology program today, led by the incredible Dr. Dennis Brooks. This is a program that has been 18 months in the making. For many of you who are in the waiting room, you would have seen the video that was in there. We filmed that a year ago now. It has been a long, hard slog and a huge amount of work by all of our amazing speakers and presenters, by Dr. Dennis Brooks, by all of the team back here at the Equine Practice Company. And we are just so excited to get this out to you. We released this to a very small beta group a couple of weeks ago, and they are heading through that. They're a month in now, and they're absolutely thrilled with it as well. So here we go, guys. This is now available for you as well. So every equine vet, if you've been in practice for more than 5 minutes, you're going to face that same call from the frantic owner. You've got a horse with a cloudy eye, a weeping eye, a ruptured eye. The owners are scared. You're not feeling very confident. In these cases, the pressure is really on you. You've got those problem eyes, the clock is ticking, and the confidence can definitely waver. So right now, eye cases might feel like a source of anxiety for you, but in a few months from now, you'll be the vets that other vets call when they get that problem eye case. I have definitely been there too. Early on in my career, eye cases terrified me. I'd be driving out to a call and just think, oh, I hope this is not ruptured. I hope I'm good enough to be able to treat this. I hope I know what I'm doing. The Equine Ophthalmology program, we've put this together for you, our colleagues around the world, and this is a guided system for mastering eye cases with the same confidence and precision that you saw from Dennis today. So this is practical case-based learning from the world's top equine ophthalmologists. So if you have ever felt uncertain managing a melting ulcer, a ruptured cornea, or a deep stromal abscess, you don't have to rely on luck, guesswork, or referrals anymore. This program will show you step by step how to diagnose, stabilize, and treat the full spectrum of equine eye cases from initial field assessment to advanced surgical referral decisions, so you can deliver the outcomes that the owners will remember forever. So this is not just theory. It is practical case-based learning from the world's top equine ophthalmologists. And we're thrilled to be able to bring them right here to you in your living room, on your mobile phone, in your truck, wherever you are in the world. When I first approached Dennis about building this course, I said, Dennis, imagine if every equine vet could learn directly from you. The same frameworks, the same judgment calls, the same calmness under pressure. He laughed and said, that's exactly what horses need, and that's exactly what veterinarians need. So in this course, you will learn from Professor Dennis Brooks, who's repaired thousands of corneas and has literally written the textbook on equine ophthalmology. You'll learn from other amazing speakers such as Brittany Martabano on recognising the early signs of uveitis and glaucoma, from Bianca DeCosta Martins on managing ulcers before they rupture, and the very popular Professor Richard McMullen on triage, IMMK, ultrasound, and more. These are the clinicians that you want on speed dial when you're standing in the field with a horse with an eye problem and a worried owner. And these guys are going to be accessible for you because you'll have access to their teaching and their recorded Q&As inside the program. So I'm going to take you through the modules now. So module 1 is all about the introduction and practical anatomy. For many of you, it has been a hot minute since you've been at university and have learned about the anatomy and physiology of the eye. It is so important. It is a foundation for everything we do, from examinations to treatments to surgery and more. The module 1 will build your foundations by understanding the functional anatomy and physiology of the equine eye, so you can recognize what's normal, spot subtle pathology early, and interpret clinical signs with clarity. Next comes the equine eye exam. So this is where you will learn to master a structured, repeatable ocular exam from menace, dazzle, PLRs, staining, tonometry, and nerve block. So you're never going to miss a critical detail. Module 3 is all about the hazy or blue eye, where you'll learn to differentiate between corneal edema, ERU, glaucoma, immune-mediated keratitis, and act decisively to preserve vision. Moving on to module 4, this is about the management of corneal ulcers following the 5 A's framework: antimicrobials, antiproteases, atropine, analgesia, and address the cause. So you can stabilize ulcers before they spiral into emergencies. One of the really hot topics right now is collagen cross-linking in horses. You've heard Dennis touch on this today. He's going to be taking you through in detail exactly how to perform this. There are some rules that you will need to follow. Also, for those of you in Australia, we are talking to a compounding pharmacy about making or getting riboflavin manufactured to be commercially available, because right now it is very difficult to get. So this is a space to watch, and this is something that you can do in the field. It is not difficult. You just have to know how to do it. Moving on to module 5, which is all about the deep and ruptured ulcers, how to apply your emergency first 24-hour stabilization plan, your intensive medical therapy, and you'll learn when surgical intervention or referral is required. Module 6 is all about corneal surgery, so understanding indications, graft types, keratectomies, conjunctival flap techniques, so you can make sound surgical decisions that protect sight. Module 7, all about ocular neoplasia. Identify and manage ocular tumours early with clear diagnostic pathways and treatment strategies that are going to achieve the best outcomes. Module 8, eyelid disorders. So you'll be able to confidently repair lid lacerations, manage entropion, and handle adnexal disease while maintaining long-term eyelid function. I still think that surgical eyelid repair is one of the coolest suture patterns that we have in equine practice. Module 9 is about handling complications, because everybody gets complications. You will learn how to prevent, anticipate, and troubleshoot complications in corneal and adnexal surgery, including subpalpebral lavage system placements and postoperative care. Module 10 is our special topics, and this is actually a bonus module for you. So you will be able to tackle advanced and less common presentations such as uveal cysts, retinal detachments, and pre-purchase red flags that can impact vision. This is a complete learning toolkit. You will also get the case-based videos filmed with real horses and narrated by Dennis himself, showing exactly what to look for and how to respond in practice. You will get interactive mentoring sessions where you can submit your own cases and receive personalised feedback from our teaching faculty. You will get community access, so you are never alone. You'll connect with other vets, other equine vets who are learning, sharing photos, and solving cases alongside you, remembering that eye problems are the 4th most common reason vets see horses in clinical practice. And because this is the initial launch, we've added an exclusive bonus that I'll share with you in just a moment. And also, not to forget, the ophthalmology program is registered for 31.5 race credits. So every hour you invest in the program counts towards your professional development. So can you see how a repeatable system like this, like the ophthalmology program, is going to take the stress out of eye cases for you? Isn't it going to make your next emergency eye call easier? That is exactly why we built it. So now let's talk value, because I know that you're thinking, oh, this sounds amazing, but how much time and cost are we actually talking about? So here's the reality. If you tried to piece this level of training together on your own, so attending live workshops, conferences, buying textbooks, taking time off work, you would easily spend $10,000 to $15,000 very quickly, and you would still not have the structured, guided experience that this program would give you. Or if you continue to refer every challenging eye case that's out there, that is thousands of dollars in revenue that you will never recover. You will never get to learn from the case. And even more importantly, you'll miss the opportunity to expand your skill set and your reputation in the field. Most ophthalmic cases billed correctly return $3,000 to $5,000 or so to your clinic. So even one saved eye case pays for this program several times over. The Equine Ophthalmology program gives you that same mastery for a fraction of the cost. So today is going to be our initial launch, and when this program officially launches to the public, the full purchase price will be $6,999 or $699 a month. But because you are here today, part of this initial launch group, you're getting a massive price discount as a thank you for being early and helping us to shape the future of this program. So your investment tonight is just $4,499. That's in USD, or 12 monthly payments of $449. So that's it for 12 months of full access, all current and future bonuses, all updates, and everything that you've seen here today. It's there waiting for you. So right now, 15 veterinarians have already joined during our beta test last month. They've been in a month and they are absolutely loving it. So it has been amazing to watch the momentum build already. A couple of vets have already joined before we started the masterclass. We hadn't even published the URL, but they've been able to find it and purchase. And the chat is full of familiar names from our other programs. So it is very clear to us that this community of equine vets is growing fast and raising the standard of equine eye care together. So let me sweeten this a little bit, because I want to reward those who take decisive action. If you enroll today, you will also receive some bonus training on managing corneal ulcers when there is tissue loss, and that's by Professor Dennis Brooks. The second bonus is another training, which is how to integrate ophthalmology into equine practice. So even if you're not seeing a lot of eye cases at the moment, this bonus lecture is going to take you through how you actually integrate it into your practice so you can see more eye cases, and so to be able to apply your new learnings. Every horse has a pair of eyes, right? You will also receive, as part of our exclusive launch bonus, a live group mentoring call with Dr. Dennis Brooks, and that is happening in 2 weeks from now. So that is something not to be missed. It's a small group where you can bring your cases. We discuss them in detail. It is an incredible learning experience. Now, for this launch only, we are keeping this founding intake intentionally small. So we have capped this at 50 veterinarians. So we're going to take a total of 50 veterinarians over this promotional launch period. And this is so Dennis can personally engage with the group and in mentoring call. Once those places are filled, our enrollments are going to close until 2026. I do want you to know we have taken all of the risk off your shoulders. If you join and within 30 days, if you don't feel it is exactly what you've hoped for, just email us. You'll get a full refund, no questions asked. We have made this completely risk-free because I know that once you get inside and watch those first few lessons, you will realize that this is the missing link between knowing and doing. So here's what I'd love you to do next. Click the Enroll Now button just below this page, choose your payment option and secure your place before enrollments close. I'll get the team to drop the link in the chat section for you. It's the equinepracticecompany.com/equine-ophthalmology-program. One of the funny things about the ophthalmology program is I've learned how to spell ophthalmology correctly. It's a hard one to spell. Once you have joined, you are going to get instant access to Module 1. So that's the Introduction Anatomy. You'll also get instant access to Module 2, which is the examination of the equine eye. plus your bonus library, and you'll also get a welcome link to our private community that you can get straight into and you can literally start learning today. As you move through the training, you're going to start noticing things you never saw today. Subtle changes in the cornea, early patterns of uveitis, new confidence in how you speak with clients. You will see things in your eye photographs that have been there all along. You just didn't see them. This was illustrated in our private meeting with our beta group last week. Once Dr. Brooks pointed something out in one of those photographs, you just couldn't unsee it because you've learnt it. So this is when it clicks. When you're no longer reacting to emergencies, you are going to be leading with certainty. So 6 months from now, I want you to think back to this moment right now, the moment when you decided to stop guessing and start leading. This is the turning point for your clients, your patients, and your future self. Thank you so much for being here live. You are exactly the kind of veterinarian this program was built here for. If you've taken the time out of your day to join us, this is for you. You are committed, you are curious, and you are ready to raise the standard of equine care everywhere. Dennis and I cannot wait to see you inside. We are so excited to present this to you and just can't wait for you to get started. So just a quick note, if you head over to that link, the equinepracticecompany.com/equine-ophthalmology-program, there is a chat widget on there as well. So if you have any questions, that is manned 24/7 right now. So you can go in and ask us some questions and we'll be there and be able to answer immediately for you. And if it's something we don't know the answer to, we'll go and find out and we'll get right back to you. Okay, so I think we are ready to take some questions.
I got Myra Soriano. Can horses see colors? Oh, absolutely. They don't see red, Myra. They don't have the photoreceptors to see red. So they see blue, they see yellow and green well, but they see red probably as a gray color. Their eyes are also adapted really well for seeing in the dark, and their eyes are superbly developed for detecting motion. Hope that helps. Olivia Schlichting, can you tell if a horse has 20/20 vision? Oh, actually, what they have is 20/35 when people have used the refractometers and stuff. So they're a little not so good as us, but they're better than cats and dogs, which are like 20. I think a dog is 20/75 and cats are 2100 or something. Ruth Sobek, is there a reason to restrict exercise for uncomplicated resolution of a simple corneal ulcer? Absolutely not. Exercise them. If the ulcer, the reason people sometimes want to restrict exercise, Ruth, is because if they have uveitis, if they have a lot of uveitis, that means the blood vessels in the iris are weak. And so they don't need the pounding of running. That doesn't help the eye heal. But if it's a simple ulcer and there's little to no uveitis, I'd have a normal exercise. Why is it preferable to stop antimicrobials first? Oh, Ingrid, that's a really good question. Because I don't think they're doing anything after a while. I think that you stop them first and make sure that and then keep the anti-proteases longer, the anti-uveitis drugs later. Ingrid, I don't think it's that hard to get the infections under control most of the time. But however, if the infection is a beta hemolytic streptococcus, then I'd probably not stop the antimicrobials ever. But generally, I can stop the antibiotics first. Tori, let's see, if corneal edema is severe, yeah, see, that's the thing about the dazzle. The light will go through corneal edema. It'll go through hyphema. It'll even go through a small pupil to stimulate the retina. That's why I do the dazzle. Corneal edema doesn't stop at all. Like even if there's a cataract, light goes through a cataract. Its images don't go through a cataract. Yana, can you accurately assess dazzle on a sedated horse? I do it every day. Absolutely. Every day. Can you use regular ULS gel on the eye? Oh, yes, you can use ultrasound gel on the cornea, is what you mean. I do it every day. And then just clean it off when you're done. When you do a side dose, this is Jennifer Swin. Oh, just for the sake of asking, when you do a Seidel's test, do you apply proparacaine to the cornea first? Proparacaine or tetracaine? Or Jennifer, sometimes I use carbocaine for nerve blocks and so forth, or lidocaine sometimes. You can put that on the cornea. And Jennifer, and if you want to do something that's If you have to put a suture in the cornea ever in your life, do the topical anesthetic like proparacaine or tetracaine, and then do the lidocaine or carbocaine also. Do them both. I don't think the proparacaine and tetracaine work very well in the horse. I know the evidence disputes me on that, but add the lidocaine or carbocaine as well. Is collagen cross-linking, is it once? If it's really bad, if it's really not a bad situation you're in, probably once is enough, but sometimes I do it daily, sometimes I do it weekly. And I use the 6-minute protocol. So I let the cornea soak in riboflavin by spraying it on the cornea for about 20 minutes. And then I do a 6-minute application of UV light because I'm achieving 19.5 milliwatts per centimeter squared. And see, you need the collagen cross-linking, you need to know how much light, how much power is coming out of your light. So you need to buy a little photometer at the same time. They're not very expensive. And we're going to develop a program here real soon showing people how to do this, how to evaluate the photometer. You can buy a $2,000 laser to do the light, and I got a $45 one, and I know it works fine. What wattage of light? Oh, I was just looking at this last night. You need to achieve 19.5 milliwatts, and I think you need 300 lumen. Vicky, you and I need to talk again because my memory is poor on this. But if you Google CXL collagen cross-linking, somebody will tell you the wattage. I'm sorry, I'm just stupid. I can't remember it. How do you calculate? Use a photometer to calculate the light dose. What that'll do is that'll take how much light's coming from your light, and it'll also tell you how close you have to be to achieve 19.5. And I don't have a video to show you tonight. I wish I did, because if I showed you, you'd go, "Oh, got it. It's not hard." Where do the collagen grafts come from? I have my own cornea bank. And when a horse dies from non-infectious disease, laminitis or old age or whatever, I go to the owners of the horse and I say, your horse can help another horse. Donate the eye. I've never been refused. And then I have another video to show this, Janine, as well, how you take the eye out, you nucleate the eye when the horse has passed away, and cut out the cornea. I got a video that shows exactly. It's not hard. You just need some scissors, and then when you put it in an antibiotic, like triple antibiotic bottle, and put it in a freezer, and I throw it away after 6 months. Oh no. I got new questions and I've screwed. Let's see. What kind of light? The light I have is for hiking and it has UV light built in. There are also military grade UV lights or police grade. The police use UV lights to look for blood spots in crime scenes. You can get them on Amazon or similar places. Oh no. A bunch of new people came in. That's good. I'm loving it. But I did that one. Corneal. I'll get it here. Bear with me. What is the light? I missed. I don't remember that one. How do you calculate that? So you need a photometer. When you remove that, is there an issue in harvesting from the horse that have been? No. What I try not to use is a horse that's had a systemic infectious disease. How do I store the corneas? They're stored in a bottle of antibiotic, usually triple antibiotic bastration, just in a regular refrigerator, freezer, not a ultra freezer, just a 20, I think it's 20 degrees Celsius freezer. Oh, there we go. Marina Caesar, she put some information. Marina, thank you. Any idea? Yeah, where do you get riboflavin in Europe? Strula. There's a company named Strula, and you can buy, and I'm probably mispronouncing it. Sorry, I'm just a dumb American. But you can buy it because I know I have a picture in my lecture on collagen cross-linking of the bottle that you get it from in Europe. It's pretty widespread. It's easier to get it in Europe than it is anywhere else, evidently. How long should a horse with corneal be kept on systemic nonsteroidals? How long? I try to get them off of the Banamine. I use fluorescein, and I try to get them off fairly as soon as I can. I go from twice a day at the low end of the dose, half dose twice a day, and then I go to once a day at the half dose. And then depending on how the horse is doing and what condition I've got, so I wean them off. Santana, I hope that helps. How do you diagnose aqueous flare with a slit lamp? And it helps me. Oh, the real question, Isabel, is thank you for asking. Atropine. Atropine does three things. They're all equally important. One, it dilates the pupil to minimize contact of the iris with the lens, to minimize synechia forming. That's one, dilates the pupil. But most people think that's all it does. Atropine is the only drug we have that directly reduces aqueous flare. Atropine topically makes the iris blood vessels, the iris capillaries, stronger. In uveitis, they're weak. So I can have a atropine with the pupil, the pupil stuck to the lens, it doesn't move at all. I can still have atropine being useful because it gets rid of flare. And then also, the third thing atropine does, it helps with relieving spasm of the ciliary muscle, which is extremely painful in the horse. I've got horses who only have inflammation of the ciliary body, and the only treatment is atropine because I can't get them off atropine, otherwise they get painful. Atropine's the only drug. So atropine, I'd love to talk to you, Isabel, about that, and I will talk about it in more detail. Atropine needs to be used, or similar drugs. It doesn't have to be atropine. It can be tropicamide, cyclopentolate, but they need those drugs to make the iris capillary stronger and reduce flare. They also need it to dilate the pupil to reduce the chance of synechia forming. And then third thing is helping reduce the eye pain that's associated with uveitis, whether it's uveitis from equine recurrent uveitis or whether it's uveitis from a corneal ulcer. Atropine does three things. And I talk to vets every day about cases, and if they're using atropine, I ask, "Are you using atropine?" They say, "Yeah." I say, "How often are you using it?" They say, "To effect." And I go, "What effect are you talking about?" And I know what they mean. The pupil being dilated. But atropine does more than that, Isabel. It does more than that. Or atropine or similar drugs. Does the ultrasound probe go directly on the cornea? I used to never put it on the cornea. Now I do most of the time. You just have to be careful. I'd say yes. Yes, Zoe. Does Cushing's affect eye healing? We can't directly say it does, but you seem like you see some superficial non-healing ulcers in Cushing's horses that you can't get to heal. So we don't know. We don't know for sure, Andrea. Camilo, eye ointments versus eye drops, which are best? Depends on the owner and the horse as to how the contact time of ointments is probably a little bit better than eye drops. However, Camilo, they're only there 7 minutes. The horse eye, the tear production is so massive, it just flushes everything out. So it's whatever is easiest for the owner of Camila's. I don't care. If a horse has uveitis, how often do you administer atropine? That's a good question. 4 times a day maximum. I'd rather, if it's a horse with a corneal ulcer that has uveitis, probably 3 times a day. It makes me nervous when they're on it, but it does those three things, Sarah. I know it. Let's see, Jelena, long-term eye issue from ulcers to white eye, always leaking, always tearing. Is now as you know that yeah. So it's a horse with chronic uveitis, and the eye's shrinking, so it's thesical. Oh, yeah. So Jelena, Jelena wants to enucleate, but the owner just can't do it because the owner probably doesn't like. Her question is, as veterinarians, do we stand our ground? And we represent the horse. So I guess being diplomatic, Jelena, you still need to say, this horse is pain. You know what'll happen, Jelena? And you know this yourself. If you or somebody enucleates this horse's eye, that horse is going to feel better instantly. And the enucleation surgery actually is very painful. In people that get enucleations, it hurts. So let's just assume the same thing happens in horses. Nearly all the time I enucleate a horse eye, that horse feels instantly better. telling me that they were hiding how painful. Jillian, tell the owner that. Tell her that enucleation in people does hurt, but that when horses get enucleated, they feel better. And maybe that'll help advocate for the welfare of the horse. Now, don't give up. But you have to be diplomatic, and maybe you're not diplomatic, but I don't know you, but I'd like to. What form of riboflavin? Vitamin B2. I think, oh, I knew somebody was going to ask me this. The light source I get, I can show you. I get it from Amazon. It's just a hiking light, but it produces a 19.5 milliwatts per cubic centimeter of light at three centimeters away from the cornea. And what dose? I think the riboflavin, I think it's 0.125%, but I may be wrong. I need to look that up. When to use serum over plasma? I tell you what, I use serum for melting ulcer. I use plasma for a superficial non-healing ulcer because plasma has fibronectin in it, and fibronectin is necessary. Logan, you hear me? Fibronectin is necessary for a corneal ulcer to heal. You need fibronectin on the surface of the ulcer. It's like a biological glue, but not as good as an adhesive as the other ones we were talking about. But you need the fibronectin there for the cells to migrate on to heal the ulcer. So if it's a real melting ulcer, I think serum may be a little better. I hope that helps. That's a hard question, Logan. Logan, probably the truth is you can either one. It doesn't matter that much. How do you apply eye medicines? I got some horses on 5 or 6 medicines 5 or 6 times. And one of my owners said she was treating her horse's eye 450 times a week. I don't spray it on. I drop it on. If you're using liquids, 2 drops of each medicine at a time. If you're using an ointment, 5 millimeter length, 5 millimeter strip of medicine. Is Tylenol or gabapentin okay for pain control, painful eye cases? I think it helps. I think it helps. But I think Flunixin is much better. Or Flunixin and Tylenol. I hope that helps, Leah. What should I do if I see an eye with a corporate nigrans attached to the cornea? Ooh. I try to dilate the pupil and see if that tears it loose. Is it causing vision problems, Jessica? Is it because horses can see enlarged? You might have to have somebody laser it. Don't stick a needle in it. Whatever, do you recommend what? If ever, I use atropine all the time. All the time. It's required. I had a horse vet from Hungary write me and told me he thought using atropine was contraindicated. No, I disagree. 1% atropine twice a day at least, and I have it on for weeks. What could be the cause for lack of neovascularization on a chronic ulcer? Oh, I wish I knew the answer to that, Andrea. I wish I knew the answer to that. Fungal infection. And then maybe some of these horses have an inherent healing problem, and it's that. Is it rational to use collagen cross-linking in a cornea which has been patched? Oh, absolutely. Why not? Richard, go for it. What about using platelet-poor plasma for eye ulcers? It's probably okay. Is it sterile? I'm stupid. I don't know the processing you're talking about, but I think it'd be okay. Is atropine contraindicated in No. It actually probably helps increase the unconventional outflow in the horse. It makes me nervous to do it because other animals, you don't want to use atropine in glaucoma cases, but the horses seem to tolerate it real well. And I've done it for years. You do realize, Zoe, that I'm the person that wrote the paper that suggested atropine was a bad idea. But anyway, it was a long time ago. How do I make plasma eye drops? Put the blood in EDTA or heparin and spin it and take off the diluent. I think that's how I do it. If you see a horse with antifungal, antibiotic, atropine plasma, does it matter which order? Ooh, no. No, but not at the same time. Why can't you use EDTA with serum? Well, because the antiproteases don't mix together. That's the simple explanation. You just can't. They stop being. If you dilute an antiprotease with something else, you reduce the antiprotease activity, which maybe not makes any sense. And that's just empirical. We found out doing it that way. If white cells are in abscesses created after ulcers, and is that the natural response? Yes. An injured cornea attracts neutrophils. They're the enemy. If they attracted, Martina, if they attracted macrophages or monocytes, things would be a lot less bad. But the horses attract neutrophils. What are the ideals to apply? When to apply glue? What are the ideals? Apply glue in small micro leaks, small holes. That's when I do it. Where do the collagen grafts come from? You can, in the States anyway, there are several sources of them. You can use amnion as a source of collagen. You can use, which is for sale, and I think it is in Europe too. Australia, I don't know, but we can find out. You can also buy liquid collagen, liquefied amnion, which is a source of collagen, and I use that too. So you can have corneas, amnion, small intestine, submucosa. There are several sources of amnion for collagen. Several sources of collagen. Sorry, I'm getting crazy. How do you calculate the light dose for? You need a light meter, Emily, and it's real easy to do. Vicky, I don't know that one. Oh, I've seen these. Okay, I think I got to go down here. Can I do a few more?
Sure. Nobody's leaving the webinar, so you can go as long as you
Oh.
want, Dennis.
I may have screwed up the list. Everybody's going to be mad at me. How do you treat a stromal abscess? It's a new Heidi. They're all fungal. So try a topical antifungal, an antibiotic of some sort, like usually ciprofloxacin or one of those type drugs, atropine, and systemic flunixin, sometimes a systemic antifungal, fluorescein. If that doesn't work, but Heidi, one of the new things that's really exciting is injecting voriconazole, injecting amphotericin B, injecting it into the abscess. They make special needles now that you can't go all the way through the cornea because they're only like 0.6 millimeters. In the horse cornea is 1 to 1.5 millimeters. These are 0.6. So you can inject it into the stroma, and that seems to help a lot too. That's how I treat them medically. And then if that doesn't work, they go to surgery if the owners want. Can large iris spots, so can ciliary cysts or corporate nigra cysts affect vision? Oh, absolutely. Larry, I'd recommend that you find somebody with a laser and pop them rather than put a needle in the eye. But that's a whole nother. We'll talk about that in the course. Do I do culture and sensitivity on eye swabs? Oh, yes, I sure do, Jess. What antibiotics do we use initially before getting culture results? That's a common, Laurel. That's a common consideration. You got a horse on antibiotics and then you want to culture them then? Guess there's my philosophy, Laurel, on that. If you're on an antibiotic and the case is getting better or not getting better, and then you culture it then, well, and you get something to grow, then the antibiotic you're using is wrong. I don't worry about whether they're you get a clean culture. If they're on something and the ulcer is getting worse or the abscess is getting worse, then it's okay to culture them and look. And then if you may find an organism or a fungus that is resistant to the antibiotic you're using. That's why you're doing it, Laurel. Acute corneal edema in horses where descemy is ruptured. Oh, how do you do it? That's a good question. Edema is blue. Keratomalacia is more yellowish. It can be a little blue though. Oh, yes, sir. That's a good question. Especially in corneal opaque cytology is not feasible. If you have keratomalacia, yes, sir. It's going to stain with fluorescein. If you have edema from descemet's membrane rupture, it won't stain. Yes, sir. If that doesn't help you, Olivia, and you and I can talk about it. They keep showing up here, and when do you nucleate a glaucoma case? Hi, Laura. If the eye's blind and painful and needs medicine because it's painful, then it's time to enucleate. Can you use CLA? Yeah. Some people don't use cross-linking in deep ulcers. I do. People do worry about it. And there's some veterinary ophthalmologists that won't do it in deep ulcers, and I've never seen a problem with it, so I do it. What do you think about? One last question, Martina. What do you think about intravitreal injection of gentamicin for uveitis? I think it's a reasonable thing to do. There are some people a lot quicker to use it than me. We're going to talk about that in the course too. How do you know if there's a posterior uveitis when the cornea is so edematous? Ah, well, measure the intraocular pressure. And if it's low, then you probably have posterior uveitis. When do you consider when deciding if and when to you? If you have a non-healing superficial ulcer, not deep, debride it right then. Then the question is, when do you do it again? If you stain it with fluorescein and you look and see if there's any roughness around the edge or smooth. A corneal ulcer, if the edges are smooth, don't debride it. If the edges are rough, debride that part. Roughness on the edge of the healing ulcer indicates dysplasia of those cells. Andy, does that help? When do you choose to use EDTA over serum? I use them both. EDTA, I use EDTA and serum and plasma in the same eyes. Heidi's going to email me some pictures. Do I have any experience using exos? I do not, Maria. I'm sorry. Let's see, Jenna, you're good. How do you treat it? I think I might have got him. Don't be mad if I missed you. But blame Olivia.
Blame me. Blame my internet.
If you have a question, send it to Olivia, and I'll answer it. I think
Yes.
I think I got it. I probably didn't, but I did my best for tonight.
We appreciate you all giving up your time to be here and to learn from Dr. Brooks. I know that myself, I learn something new every single time, and I've got half a page of notes of things that I have learned. Generous of you to be able to share your knowledge with everybody around the world. So we have people from, I think, over 20 countries on here today.
Is that
in
right?
all
Excellent.
Different time zones. It's very
That's a record.
Some people, yeah, 20 countries. Yeah, we broke the internet today, I think, with all the people on here.
Somebody from New Zealand.
Dennis, thank you again so very much, and everybody, thank you for joining us. Head over to the OL Equine Ophthalmology program. Go and have a look at it and see if it's something that interests you. We are thrilled to finally be able to share it with you, because as I mentioned at the beginning, Dennis and I and the amazing group of speakers and our whole team have been working on this program for 18 months. It has been a long, hard slog, and it's ready now. We've already got people going through the course, so we're really thrilled to be able to share it with you and to raise the bar on the knowledge, skills and confidence for equine vets around the world, all continents, to be able to help them.
No more blind horses. No more blind horses. No more blind horses. If we can help, no more blind horses.
Yeah.
I'm going to head out.
Dennis, you mentioned that eye cases are the fourth most common reason that vets are called to see horses. Definitely worth educating yourself
in the
on.
US, yeah.
Okay, we'll draw it to a close. Thank you, everybody, for attending. Dennis, again, thank you. I can't thank you enough. You are incredible. I love learning from you. So very grateful that you were here. So we'll draw it to a close. Thank you, everybody. Have a good evening or a good day wherever you are.
Bye, everybody. Take care.
Bye.